Dr. Sabar, the stage is yours.
Hello, Berlin 2020, and thank you for joining my talk. Imagine me trying to talk about the importance of taking care of people in their own homes about 200 years ago. As an audience, about 200 years ago, you would have probably thought that this talk is completely irrelevant. It's pretty much like talking about the importance of breathing. You would ask yourself, how else will we take care of people if not in the comfort of their own homes? It's what we as physicians have been doing all these years, since the first man in a cave met the first shaman. Well, hospitals have been around for about as long as the Greek and Indian empires. They've been around for a long, long time. But throughout the ages, even though they've changed, they were pretty much not medical institutions, they were religious institutions. And you would go there for three reasons. One, either because you were dying, or two, because society has driven you out, like in the case of leprosy, or the combination of the two. It's only about 200 years ago where medical pioneers such as Thomas Percival and Florence Nightingale have redesigned hospital care pretty much to the way that we know it today. And in the last 200 years, the pendulum of taking care of people shifted completely from their own homes to the hospitals and the large clinics. And the vision of seeing medical people, medical personnel, moving from one home to the next, taking care of people in their own homes, is something that most people rarely or never even seen in these days. In the few cases where it does happen, it's usually in the case of dying of very ill chronic patients. Many of us believe today that history is coming back. And just like the largest taxi company in the world has no taxi of its own, Uber, and like the biggest hotel company in the world has no hotel rooms of its own, Airbnb, we believe that in the very near future, the largest and most comprehensive hospitals in the world will not have one single bed of their own. And just to give you an example, I'm the founder and the head of the fourth largest hospital in Israel, and all of our patients are inpatients in their own homes. Well, although it's a natural course of events, and going back doing what we've always done, it's still something that we have to go back to the drawing board and to our schools to learn how to do it well all over again. Because even though it's about patients and medical teams and medicine, they are not the patients they were 200 years ago. We are not the same medical teams, and it's definitely not the same medicine. It's no longer a question of why taking care of people in their own homes is a good idea. I believe that everybody now believes it's a very good idea. It's only about the question of how and whom should do it. And for us, as primary care physicians, as family physicians, this is a wonderful opportunity to reassert the importance of our profession. But paradoxically, even though taking care of people in their own homes seems like it's only about benefits, paradoxically, it's an environment that leaves or might leave both the healthcare professionals and the patients even more vulnerable than in other situations. And I'll explain. As far as the medical team is concerned, it has the potential of leaving us more vulnerable for two reasons. One, lack of tools. We just enter the patient's home and this is what we have. The information that we have between our ears is all our tools. We don't have immediate labs. We don't have highly skilled other professionals to consult with us. We don't have sophisticated imaging like CT or MRIs. We don't have all these tools. What we know is what we bring. The other reason we are paradoxically more vulnerable is because we have nothing to protect us between us and the patients. We don't have large desks. We don't have overcrowded waiting rooms. We don't have very eager secretaries to protect us. We're very exposed. It's just us and the patients. In other words, what we know and who we are is what we bring to the scenario. And that's why we're potentially more exposed. Now, as for the patients, well, you can read this quote, which basically says, a person's home is his or hers castle. And when we enter their homes, even as a medical team, especially when we enter their homes a few times a day or with different medical teams or different staff. We have the potential, at least, to give them the feeling that their castle was invaded. And I'll give you a few examples. When people leave their homes, whether it's to go to work or meet their friends or go see the physician, people choose to don on masks or don costumes. They decide how they want to present themselves to the world. They decide what they want to bring with them to the outer world, and more importantly, what to leave in the privacy of their own homes. But when we enter their homes, nothing is a secret anymore. We have the potential to see relationships, living environments, personal and sometimes very intimate artifacts. For that reason, it's no surprise that in these days and age, norms and practices, for some people, this entering of medical teams into their own homes might feel like an invasion. Now, I've learned the very important thing about what people decide what to bring with them to a medical encounter and what to leave in their own homes with an experience that I had with a wonderful family physician who's passed by now, unfortunately. His name was Dr. John Cohen. And when Dr. John Cohen welcomed me to a month-long elective in his clinic in Fitzrovia Square in London, the first thing he told me is that a medical doctor, a family doctor, needs to know how to manage a waiting room. He has to know the dynamic of waiting rooms. And therefore, before I could go up to his clinic and sit with him and see patients, I had to wait in his waiting rooms for 3 days. And I thank him to this day for this wonderful gift that he gave me. Sitting in that waiting room for 3 days and watching patients and hear them talk to the secretaries and talk between themselves, I heard about the big difference between the encounter when the medical doctor thinks it started and when patients actually started the encounter. For the doctor, the patient-doctor encounter started when the patient entered their office. But for the patient, it started almost 2 weeks ahead of time, when they first felt that something was wrong. Was it pain or shortness of breath, or something that told them that they need to see the doctor? By that time, after a few days, they said, we should really see the doctor. And then at that time, thoughts are starting to run in their heads, mainly anxious thoughts. So they make the arrangements. They take the time off work, they have an arrangement with the kids, they make the time available, and they go to the appointment. So by the time they're sitting in the waiting room, it's the apex of the waiting period, and the thoughts are running in their heads very fast. By this time, they have the opportunity to decide, this is what we want to bring to the encounter, this we want to leave at home, or they even have the potential to cancel the meeting altogether and go back home. Now, all these options are completely gone when the medical teams enters their home. They cannot hide the reason why we're there. We know why they called us. They cannot cancel the meeting, and we see everything, the environment, their bed, the interactions between their members of the family. We see if there's neglect, if there's well housekeeping. We see everything. There are no secrets. So again, it's no wonder that people might feel vulnerable at this point. In most cases, patients did not have the opportunity to practice ahead of time the experience of a medical team coming to their own homes. For all their lives, they've rehearsed and rehearsed again the role of guests. They have been our guests in our hospitals and in our clinics. But now when the medical teams comes to their home, they have to play a completely different role, and that is the role of the host. And a whole new set of questions arise in their heads. Over and beyond the regular questions of, will I be okay if this medical team is well equipped? Do they listen to what I'm saying? Will I be safe? These are usual questions, but now they have to ask themselves questions like, is my house clean enough? Should I offer them something to drink? Maybe they're vegetarians. Maybe they keep kosher. Do I look okay? Is it okay if I sit here, or should I stay in bed? All these questions are new now. And they're all from the part of being a host and not just being a guest. Now, it's completely okay to feel uncomfortable in an environment that's not your own. But when a patient feels uncomfortable or unsafe or not sure in the comfort of their own home, that is at least a risk factor for feeling more anxious, or what we call a cognitive dissonance. We've all had professionals come to our home all the time. We have cleaners, we have delivery people, plumbers, maintenance people. We're very used to this encounter. But almost none of us are used to the encounter of a hospital-based medical team coming to our homes to hospitalize us in our own rooms and our own beds. Again, a reason for feeling somewhat uncertain about the role and the position of which we play. So we believe it's important. We believe that this is where the future is taking us, corona or non-corona. But we also understand that it's not as easy as it sounds like. It's not just like going back in time and doing it all over again. Today, there are potentials for both medical teams and personnel and both patients to feel more vulnerable. So, how do we do it right? What is that secret ingredient that we had to add to our already complex art of taking care of people that will make them feel safe in the comfort of their own homes? Well, I was intrigued by this question, and we looked it up in the literature, and unfortunately, we couldn't find anything about it. We couldn't find anything telling us what are the secret ingredients, what are the correct tools of how medical teams should approach the act of taking care of people in the comfort of their own homes. So we did the research ourselves. We have in Sabar, collectively, about 5,000 years of human wisdom of taking care of people in their own homes, with about collective staff of almost 500 people. So we asked our teams a very simple question. We asked them, what do you do differently when you take care of people in their own homes as opposed to what you would do if you took care of them in a hospital or in a clinic? And we got hundreds of answers back. And we sorted it all up, and we came up with two themes. One are universal themes. Things like being compassionate, listening to our patients, taking the time, having empathy. We call these universal traits because it's irrelevant where you practice. If it's in the North Pole, a hospital, in a jungle, or in the bottom of the sea. It's always true wherever you take care of patients to be empathic, to be listening, to take the time, and all these correct traits. But we also identified a few traits that were particular for taking care of people in the environment of their own homes. And the more we read, there was one particular trait or one theme that was intertwining through everything. And that is that when you take care of patients in their own homes, you are first and foremost their guest. We are their guests in their own homes. Now, we're professionals at what we do. We're medical teams, we're medical personnel. So we coined the term the professional guest, which means you have to be as professional as you can, being a doctor, a nurse, a physiotherapist, a social worker. Be the best that you can be, but also know how to do it in the correct way, in the comfort of people's own home, and make them feel both protected professionally and protected as far as their boundaries are still safe. And I want to walk you through now through the four main tools that came up from the questionnaires that we asked, which we believe are the four basic elements for having a good toolbox for being a good professional guest. Tool number one, scan, learn, and observe the patient's surroundings. Look at the things that will allow you to learn what are the sources of strength and what are the possible sources of weakness for that patient. Look around, see the surroundings. Are there fresh flowers in the vase? Is there always somebody present from the family member in your visits? Is the house clean? Is there food in the fridge? Are there recent photos of family members? All these things are information that will help you in two important aspects. One is establishing initial trust, and two, tailoring the care plan. Let's talk about establishing initial trust. Let's say I walk into a patient's home, and in the living room, there are pictures, and all of the pictures are signed G. Gonzalez, G. Gonzalez, G. Gonzalez. And the patient's name is George Gonzalez. Now you can imagine what it would do to him if I say, George, did you paint all these pictures? This is a source of saying, I am your guest. It's saying, I looked around. What is around is important for me. And this is establishing a trust. And in almost every house and every home, you can find at least one nice thing to say. Oh, a nice view from the window. Interesting collection of books. Wow, you won all these trophies in a bridge competition, and so on and so forth. And even when you don't have anything nice to say, acknowledge even that. For example, oh my God, you live on the 4th floor with no elevator. You must feel trapped every once in a while, not being able to leave your own home. What these things are saying is that I know that I'm your guest. I realize that I entered the home, I looked around, and I care about what I've seen. This causes the patients to say, this is somebody who is empathic. He looks around. He doesn't look to me as though I'm any one of the other patients. I am special in my own way. The second important of scan, learn, and observe is tailoring a specific care plan for the patient. Now, we're very good at writing down the exact treatment patients need, and some of us even take the time and write it in tables with a little icon of morning, lunch, and evening, and sometimes we even put a little picture of the correct pill, when to take it at what time. But is that good enough for all our patients? Can you imagine the difference of one patient who doesn't throw anything away in their own home? The house is completely cluttered. He has the newspapers from 1956. He's never thrown any clothes away. He doesn't wash the dishes. He has all the tin cans that he's ever opened, all the bottles that he's ever drank. The house is a complete disorganized mess. Will he have the same compliance to our treatment as somebody who is an OCD? Whose everything is very meticulously in place, whose all his gray sweaters are arranged by different shades in his closets? Obviously, the answer is no. And there's no wonder why the adherence to long-term medical plans is almost about 30%. That's it. And part of the reason is because we don't tailor a specific care plan for that specific patient. Now, when we enter their homes, we have the amazing opportunity to look not only at the particular illness, but look at the patient as a person, as a whole, in his own ecosystem, and say, this medication would be appropriate, and this is completely not. Maybe even the whole idea of a care plan. For one patient, he needs to have it every day reasserted and give him a telephone call and say, you remember, this is what you have to take, because there's no way they can remember because their entire life is chaotic. Whereas for another patient, if you don't tell them ahead of time exactly what medications they're going to take a month ahead of time, they become very unsettled. So again, the opportunity to enter patients' home gives us this wonderful opportunity to tailor a specific care plan for their needs. And that was tool number 1. Tool number 2, prepare to be surprised, keep an open mind, and learn to improvise, which I know might be difficult for a few of you. But a big part of being a professional guest is realizing that we have no idea into which home or house we're entering. Once we open the door, it's a whole new universe on the other side of that door. Sometimes they're very nice surprises, like nice people, nice families, interesting life stories, great views from the window, excellent homemade cheese that we're offered. They're all great. But sometimes they can be very unpleasant surprises, like neglect, like violence, like a very unprotected environment for the patient or for yourselves as medical teams. We should be ready for anything. Sometimes you'll find yourself in a completely unexpected environment or scenario. For example, I remember about 14 years ago, my first medical visit to an Arab village not far from where I live. It was around 7 o'clock in the evening, and I entered the home not only to find the patient lying in bed in the middle of the living room with about 80 people in that living room, from ages 3 months to 83. Now that's the way in this village people come and pay respect to ill patients. They come in the afternoons and the evening to pay their respects. Now, can you imagine me saying, like I would in a hospital, now this is visiting times, everybody come out, you have to leave the room, it's just going to be me and the patient? That's not going to work. I had to make it possible to make this intimate medical surrounding of just the patient, his family, and myself, even though there were 160 eyeballs looking at the back of my head. So you have to learn how to do it. For example, in one of our nurses' bags, I found a hammer and some nails once. And I asked him, why would you have a hammer and nails in your bag? We're not doing any orthopedic surgery in homes. And he told me, this is the way that I can ensure to myself that no matter which home I enter, I can always hang an IV bag. And I thought this was brilliant. This is a classic example of how to be a good professional guest. Now you have to learn how to improvise, and you have to learn how to act differently in different scenarios. But you must have very strict protocols on how to act in very serious cases. For example, when you feel the patient is unprotected or you as a medical team are unprotected. There had to be protocols for this situation on what to do in order to keep your medical teams safe. So that was tool number 2. Tool number 3, ask for permission. Now, asking for permission is the polite thing to do always, but please exaggerate. For example, can I enter your home? Is it okay if I sit here? Can I connect my computer to your electricity? Would it be okay if I went to the toilets and washed my hands? Can I check you now? Is it okay if I sat at the table and write the prescriptions now? Ask for permission over and over again. Asking for permission is not just polite. It's letting the patient and his family know that you are a guest, that you're not in your own comfort zone. It's their territory, and we're keeping their boundaries very, very intact. Tool number 4, create a continuum to the sense of safety. When patients are hospitalized, they always have a sense that somebody is there. Even if they don't always see the nurses and doctors, they know that they're there. They have that little buzzer, they can call somebody, they know that they're protected. But when we enter patients' home, they usually feel very, very safe as long as we're there. They feel very much in control. But the moment we're out of the home visit and they're left alone, even if we left instructions, even if we told them about everything, they still have the potential of feeling very, very vulnerable, very, very afraid. And questions like, what if something happens? What if I need help? What if I need to call somebody? And this chasm of uncertainty needs to be filled. So how do we do it? We create a true, robust system of letting them know that they're covered 24/7, 365. When they pick up the phone, somebody answers. It's not an answering machine. It's a real live person, a caring person, somebody from the team. And that person has the ability, the car, the time he's paid for, getting into the car and driving to that patient. They know it's part of their job. They're not going to tell the patient, wait until tomorrow, until I'm back in my job. There's always somebody on call. And there's always somebody that you can consult with, a high-ranking physician, a medical officer, somebody that can give a sense that you're always in control. And in the cases where it's needed, we need to have telemetry, we need to have the remote telemedicine possibilities, and we need to have an entire system that lets the patient know that whenever they call, whenever they want to consult, whenever they need checking, it's always going to be done in the comfort of their own home. There's no way around it. You cannot tell a patient fighting ALS who decides not to be intubated that they need to wait a few hours until the teams come when he has severe shortness of breath. That's not an option. They need to be covered with medications at home, with a very skilled training team, with families, members, and caregivers being able to administer the first round of medications as they were instructed. All these tools have to be in place in order for patients and families to feel secure. These were the 4 tools that I believe that any medical personnel who wants to enter the world of taking care of people in their own homes, of hospital at home, should assert and should acquire if they want to become professional guests. Now, I'm sure there are many more tools out there, and I invite all of you that come up with different tools or new tools to contact me so we can add them to a collective toolbox of the professional guest. But although this period of time is challenging with the pandemic, and even before that, because we see that the future is taking us to the homes, to our patients' homes. And even though it's challenging, this is also a period of huge opportunity. And first of all, it's an opportunity to once again fall in love with the reason of why we became family physicians. Because we are the people who know the best how to take care of our patients and their families. This is the reason why we entered this profession. And now we can extend our reach way out from our clinics into a different whole ecosystem, a different whole universe of taking care of people in their own homes, because this is where the future is taking us. And as one of the doctors in Sabar told me once, where before, on the way to work, she used to tell herself, I'm going to the hospital to take care of patients. And today, she tells herself, I'm going to homes and take care of people. Thank you very much for listening.
Thank you, Dr. Sabar, for very interesting presentation. It was great to listen to your speech. In fact, we received several questions during your presentation, and I think you will be keen to answer them. Maybe I will combine one of the questions with my own interest. In fact, I was really impressed by the concept, and I, of course, can imagine that many patients would admire this kind of care. However, I think healthcare systems right now are struggling with the shortage of resources, in fact, and this system seems to be rather expensive. In many countries, there is a shortage of doctors, of course, and how this can be combined with the healthcare system. How could you afford this provision of this, whatever to say, kind of luxury care? Because, of course, it is kind of luxury. Can you say something about efficiency, efficacy of this solution?
Yes. Once again, thank you for the opportunity to be here today, and I appreciate all the questions being asked. It's true that about 200 years ago, the hospitals were designed in a way to bring in patients into where the knowledge was. Let's not forget that at that time, the most important tools were that the hospitals were clean, they were hygiene, they had proper food, not just the knowledge and the physicians and the nurses. But nowadays, we know that hospitals, for some patients, pose a risk. You have the risk of, when you're 75 or 70 and older, you have the risk of cognitive decline, of falling and breaking the neck of your hip, and of course, the whole idea of medical errors that are being done, that in the United States, they're the cause of death #2, medical errors done in hospitals, and of course the acquired resistant infections. So let's just all agree that we have to find different solutions. As for personnel, a few options are very available today, and we use them. One, the old model of only physicians taking care of patients and being in charge of the care has to be reevaluated. In America and in some Western countries, they've introduced physician assistant and nurse practitioners, and I'm a very, very strong believer in these two new forms of professionalism. And also, let's not forget that we have the huge advantage today of technology and doing things from remote. And if one thing that the corona pandemic did is that it convinced a lot of people that were skeptic before about the ability of conducting medical care and good medical care from remote. Now, I'm not saying in any way that we should replace the hands-on treatment with only people from afar and from remote. That's as far as I can, that's far from the truth. And in my operation and what we do in Sabar Health, we take care of about 1,200 people in any given point in time. All of them see nurses and physicians every week, but it definitely takes a difference for being able, or for the need of taking care of all these people every day, seeing a medical personnel. You have some units that don't need an everyday care, like palliative care or rehabilitation. They don't have to see a nurse or a physician every day, whereas in a hospital, they would see a nurse and a physician every day. For example, acute psychiatry, you can have a physician or a nurse entering every day during the first week when it's a very unstable situation, and then you can dwindle down or dilute the rate of visitation and still give very, very high end medical care. Of course, when a patient is in our home internal medicine ward, then they see a physician or a nurse every day. But again, some of the visits, as they do in Mount Sinai, as they do in other very high quality places in the United States, some of the visits are from far and not hands-on every day. So that's a few of the answers of how we can reuse our resources. If you look at an internal care classic, at least in Israel, there are usually about between 30 and 40 patients. And all in all, there are about anywhere between 6 and 8 active physicians every day in that clinical ward. So if you look at a regular day of a physician doing home hospital rounds, they see anywhere between 5 and 6 patients every day. So if you do the math, it's pretty much the same proportion of physicians seeing patients. And if we're talking about resources, resources are not just people. Resources are also funds. And there's nothing more expensive today than the model of brick and mortar hospitals. There's a reason why nowhere in the world people think that it's a good idea to build more huge hospitals, because it's just not proven itself to be cost effective, not to mention, in a lot of cases, not even very humane medical approach. So it's a very complex question to a very short, a very complex answer to a very short question. But of course, this is a huge issue now.
Okay, thank you very much for that explanation. I want to go on because there is a full blog of questions coming in, so I will try to combine them. There was a comment from Dutch GP that she had an impression that when you are talking about this home hospitalization, you are just describing home visits as they are doing in the Netherlands. So this is more or less the same procedure, the same behavior, as I can understand. But there was also a question which was, I think, quite important, because when we talk about hospital, we try to keep our patients at home as long as possible. We know that hospitals might be risky for elderly people, for some vulnerable groups of patients. But sometimes, of course, our resources are not good enough to provide high quality care. So there was a question also whether you have, what kind of infrastructure do you have behind these home hospitals? Do you have laboratories, X-ray services, CT scan, whatever? How is that organized?
Okay, so when you talk about, especially when you have 45 minutes to talk about a huge subject, which is hospital at home, you can decide either to approach it from the technical point of view or from the human point of view. I chose to look at the human point of view because I think it's more interesting. But of course, we have a huge infrastructure and logistic infrastructure behind it. You can imagine we're taking care of, as I said, 1,200 patients nationwide. It's not a big country, but it's still nationwide. The logistics from getting the teams there with the cars, the computers, the remote electronic medical record, which is cloud-based. We have the ability of taking laboratory tests every day from patients. We do ultrasounds today. We used to do X-rays. We don't do it anymore, just ultrasounds today to patients who need it. We can have remote consultations of specialists. In my vision, one day, hopefully, we'll be able to do the laundry and give the special food and dietary needs that patients need in their own homes. This is my entire vision of taking care of patients in their home. But if you take to a next level, If you look at homes as hospitals, the next level is doing electives, educational rounds, research. And I'm very, very proud to say that as for 5 months ago, Sabar Health was accredited as from the Israeli Medical Association and the Ministry of Health. We're accredited as a ward for training palliative care physicians in their being specialists in family in palliative care. So this is my view as an entire hospital view for patients, not just the patient-physician contact. It's the entire view of saying hospitals, home are exactly the same requirements as hospitals, but the only difference is that they're done at home. And Ingrid is very much correct. It sounds like home visits, and the Dutch are a phenomenal example of how to do home care at home for many, many years. But when you look at the pyramid of taking care of people at home, there are three main layers. There's home visits, with just coming and going from the patient's home with no prior relationship before the connection, the visits between the patient and the doctor, and there's no connection afterwards. There's the next level of home care, which is pretty much taking the clinic and bringing it to home to people who are not able to, they're not mobile enough. But the tip of this pyramid is home hospital. And it's all these things that we need as far as logistics and technology and the whole idea of the entire vision of taking hospitals to home. But my point in this talk was to say that technology and logistics are not enough. We have to relearn the skills of how to enter people's home. And I know, Ingrid, you've been doing it in the Netherlands for a long, long time, but it's not just all about physicians entering their homes and doing the encounter all right. It's the entire point number 4, the tool number 4 of how to make them feel safe when you're not there. And this is when technology and logistics enter the picture. So I hope I answered the question.
Okay, thank you. Thank you very much for this explanation. I think it was quite extensive. There were several questions about technologies, as you can see, because it seems that it is perhaps the arrangement which can be placed somewhere in the future technologies as well. So there was a question about artificial intelligence, machine learning. Did you think about that in your institution, in your healthcare unit?
Let's say this. Let's put it this way: if there was any working, good working device that is on the counter that I can buy it off the shelf, and which is plug and play, simple to use, with no hassles from the patients itself, and adds good added value to both the patients and the team, I would buy 1,200 units tomorrow. And what I'm saying might sound a little bit provocative, but as of today, and of course the coronavirus pandemic accelerated this trend, but as of today, even though we've been talking about remote and telemedicine for at least 20 years, there is no one particular technology that actually gives true added value to our patients or to our teams. There's some little things here and there, some applications, some monitoring devices, but nothing which is really plug and play, easy to use, which gives you proper information. For patient, to letting me know that he fell now doesn't give me any proper good information, because then I would just say, call 911 and have him taken to the emergency room if he's not a palliative care patient, of course. But I need the technology that feels the patient, the surroundings of it. He doesn't need to connect to anything. He doesn't need to just upload anything. He doesn't need to make sure that he has a proper Wi-Fi connection. And all these things reduce the chances of him using the technology, and will give me the information, not that he fell now, that he's about to fall in 2 days, because his steps has changed, his changes in positions in bed, he's opened the fridge less, he's went less to the toilet, he has a wide step when walking, he didn't open the front door of his house, he didn't call anybody, his conversations with other people diminished. All these things will indicate to me that something is happening, something is deteriorating. Unfortunately, there's nothing of the kind that's ready to use in the market at the moment. But seeing the surge of the technology frenzy at the moment, I'm quite sure that in the next few years we'll see something. But at the moment, it's all buzzwords.
Okay, thank you very much. There were several questions asking quite detailed about some quite detailed solution, but one was, it seems very interesting. How do you care with patients who require intensive care, like unit in hospital? What kind of resources do you have? How do you organize that?
Okay, as of today, if we look at the inclusion criteria worldwide of who are the patients that should be included in home hospital settings, it's two conditions. One, they needed to be hospitalized at the moment, because otherwise they're just home care units and not hospital-based patients. They needed to be, otherwise you would institutionalize them in an inpatient unit. But B, they need to be stable enough clinically not to be needing very intense ICU-like care, because then they're not in the hospital setting appropriate for inclusion in home hospital settings. I'll simplify it. If a patient needs to be monitored and their life is at risk, and the goal of care is to make them feel better, not just end-of-life palliative care, then the home setting as of today, and probably for the next future, is not the proper place to be. Hospitals are still the best place if you need a very extensive intensive care unit, if you need surgery, if you need CTs or MRIs, if you need very hands-on multiple interdisciplinary teams. These are still places where hospitals, and probably for the foreseeable future, a great role. Studies have shown that at any point in time in hospitals today, and at least in the Western world, anywhere between 20 and 40% of patients that are inpatients at the moment in hospitals should be inpatients, but in the comfort of their own homes. Hospitals should be left for the 60% of people who do need intensive care, high contact, high technology care in hospitals.
Thank you very much. It seems that we are running out of time. We are almost approaching end of the session, but for the end, I will try to combine two questions, and maybe when you answer them, we will still manage. The first one is about the safety of the medical personnel. Do you have any special solution? People are visiting homes alone and maybe sometimes in risky situation. That's first question. And the second, I think essential for many members of today's audience is there any literature describing your experiences? And if so, where people can learn more about your experience?
Okay. As for the safety, as I said in point number 2, in the tool number 2, is be prepared to be surprised and improvise. My point was that you never know which home you enter, and you have to be open-minded about how to handle yourself in different situations. But I did mention at the end of the point is that some things need to have very strict protocols. And the most important things are the safety of your teams. The teams should know what are the red lights that if they shine, they need to leave the environment. And they should have immediate access to somebody else in the team and saying, I feel that I'm unsafe. And the organization should have very strict protocols of what do you do in these situations. So, and this is very relevant to each country, to each surroundings, to each environment, to each culture. All in all, I can say that 99.9% of the patients and families feel that when teams come to their homes and spare them the need to go to a hospital, they feel privileged. This is not the same surroundings as emergency medical technicians, EMTs, or paramedics encounter homes in a very different surrounding. And I used to be a paramedic, so I remember being very, very vulnerable and very threatened at times. In absolute most of the cases, teams feel very, very safe because patients and family feel that it's a huge privilege that the hospital came to them and they didn't need to go to the hospital. So that's one answer. As far as research and literature, whereas there's an organization called the World Congress of Hospital at Home, the WCANC, which had the first international conference last year in Madrid. and this year, it's in Vienna. Unfortunately, this year, as everything else, it will be from remote and Zoom. And I encourage all of you to sign up to the World Congress of Hospital at Home. Again, WCHAH. And this is a platform where all the people who deal with anything that has to do with hospital at home. We have members from 84 different countries at the moment. 450 members attended the conference in Madrid last year because this is fascinating. And we also, that even though we do different things, we have a lot of things in common, the same questions and needs. So I really urge all of you to join us this Congress.
Okay, thank you, Dr. Sabar, for the explanation. Thank you for fantastic presentation. We need to finish right now. Thank you, Janine, for co-sharing. It was fantastic support for me. I felt much safer. Thank you all. Thank you, of course, all the colleagues who was participating actively in this session. Have a good rest of the day and the rest of the conference. Enjoy it. Thank you. Bye-bye.
Bye-bye. Thank you very much.